Hi, everybody. Welcome to the SecurAcath drop-in session. We appreciate seeing you. Hi, Steve. Love seeing some familiar names on the screen. Welcome, welcome. Our guest speaker today is Jocelyn Hill. She is from British Columbia, Canada. She works at St. Paul's Providence in Vancouver, Canada. And she is the clinical nurse specialist and educator for vascular access, oncology, and infusion care at that hospital. She also engages with the community as a past president of the Canadian Vascular Access Association and the Association for Vascular Access. Happy IV Nurses Day to all of our IV nurses, and happy Canadian Vascular Access Day to all of our Canadian friends that have joined us today. I'm very delighted to have everyone on the call, and this is an open session. There is no formal agenda. We want to answer your questions and make this a value-added session for you. Please post your questions in the chat and moderate those questions for our speaker. I'm going to pin Jocelyn to the screen now, so she'll be your primary screen. Feel free to unmute if you'd like to ask your question yourself. Just raise your hand and I'll call on you and you can unmute at that time. Again, please feel free to post your question and in the chat, and we'll kind of get started very soon. This is again an open session, so feel free to ask anything. Our goal is to make sure your questions are answered. All righty. So I'll kick things off for you, Jocelyn.
Great.
How long have you been using SecurAcath?
Yeah, no, this is great. You know, first of all, Laura and Jeff, I'd like to thank you guys for hosting this. I think it's great. And on January 25th, which is SIVA and IV Nurses Day. So I've been using this product for, I just have one here, it comes in multiple sizes, for over 10 years. And when I first saw it at an AVA conference, it you know was relatively new and innovative in the space, and I will say even 12 years later I still think it's one of those little pieces, because you know the footprint of it is not very big, but I will say that I think it's probably the most innovative thing that I've seen in the space over the last 15 years, because it really addresses multiple things. And you know the main thing being when we insert lines and we need to secure them, but also care and maintenance. So over the last 10 to 12 years, I've seen this evolution of appreciation for it, because suddenly the home community home care nurses are demanding it, because we put in about 25% of our lines, our PICs and tunneled lines, they go into the community. If we think about what our main goal is for many patients, is to get them home, right? So it addresses two needs, in the acute setting, for when we're dealing with really sick patients and the acuity is high, compliance may be an issue, nurses and patients, it addresses that. But then, once they transition care into a different healthcare setting, like the home or community or alternate care, it really is the device that I think is, not as appreciated as I wish it was. I think that we just need to keep spreading the word about how to use it, how to remove it, and the real benefits of it. Because again, we look at it and we think, oh, it's just a tiny piece. You attach it to the line that everybody uses, but it really is, quite important in terms of what we do on a daily basis. And then if you think about the patients, this for many of them, the majority of them, it's their lifeline. It could be a very short-term line, but for many of them, even if it's short-term, that 5, 7, 14 days, it's a big piece of the puzzle for them for their healing journey. So again,
Jocelyn,
I
just want to let you know I launched a poll so that we can get
great.
a sense of who's in the room and where they're from, where they work. There are 3 questions on the poll, so please scroll down as you fill out those answers, and in a few seconds I'll share who you guys are with. Jocelyn. As I mentioned in the beginning, I know more folks have joined since I started my introduction, but this is an open session, so please feel free to post your questions in the chat and we will moderate those questions to Jocelyn. Thanks, Jocelyn, for your introduction about your history with SecurAcath and where you found it. What I just got a question in the chat, I'm going to read it to you and we'll kind of start there. Curious if this device can be used with a low approach IJ-CVC. Our IR department does not suture, and currently we use stat lock on these devices. So Jocelyn, do you use them on your IJ catheters?
Yes. So I'm assuming, Susan, you mean like the non-tunneled percutaneous IJs. And yes, we had a big implementation before the pandemic, before COVID, and we were using it to replace sutures. Kind of fell to the wayside, since, and we're looking to resurge and restart that practice again, where ICU and anesthesia and IR have come back and said, we want to start again teaching our residents, because we are a big teaching hospital, how to use this, because, really a lot of physicians are getting away from sutures because they don't like doing it. It's time consuming, it's risky. And, they're constantly teaching the residents and, the med students that we see how to suture properly, especially for the internal jugular lines in the neck. And when there's this device, and it's a better device where you don't have to go through that learning curve and the risk is so low, and the benefits after, we're really looking at increasing our use of that. But it absolutely can be used for the IJs. It can also be used for the subclavian lines. We have seen it, we have been using it on some tunneled lines for patients that go home with tunneled central lines because of cuff adhesion issues. And so basically, any time that there is a catheter going into the skin, we've seen it on nephrostomy tubes, for example, by our nephrology team. As long as the French size is equal to what SecurAcath is able to offer, it can be used. And in terms of sizes, it can go from 3 to 12.
Yep, 2.6 French to 12.5 French catheters. And
so
Jocelyn,
absolutely replace an adhesive device like the stat lock, because again, when you think about the adhesive securement devices, you have to change those every week, or you should be changing them every week. And this device, you never have to change. It's for the life of the line. Sorry, Laura.
Can you show us? Go ahead. I was going to say, can you show us how a dressing change on an IJ would happen? So with your line there.
Also, I'm going to switch here. So this is a pick, but we'll pretend that this is in the neck, and the dressing, if you're using a border dressing, or even if you're using a non-border dressing, it looks similar to this, where you may or may not have the CHG disc or the hydrogel dressing, but either way, typically it looks like this. You have good view of the site, etc., with the wing. Now, to remove the dressing and do the dressing change, it's extremely easy. Just have to be aware to support the anchor as you're removing your adhesive dressing, no matter what type of dressing it is. I know there's many different types that people use. Hopefully you can see what I'm doing, but the technique that we use and teach is to hold on top of the device. So it would be, you're holding here and you're removing the dressing very carefully, right? And as you get to a point, sorry, Laura, can I see this?
Yeah.
Of removal.
It's a little low, but
little low.
You're good.
It's my plastic sponge pad here, but when you get to a point of, you're going to remove the whole dressing, we do, allow, I would have a non-sterile glove on to hold right here, because you're going to clean. You're going to clean with your chlorhexidine, 2% typically disinfectant, right? Antisepsis. And that's what happens. The important thing when you're removing the dressing is to ensure that the anchor itself is not moving around on adhesive dressing removal, because this will cause pain and discomfort, 100%. And what I teach in my classes is, and on my blitzes on the units is, yes, it will hurt if it moves, so don't move it. You know, ensure that it is stable at all times, whether you're holding here or, you know, once you're in a situation where you've removed the dressing, that there's not this movement of the anchor.
We do want to lift it all the way for cleaning though. So can you show what that
so once you
like?
remove the dressing, you're going to lift up, and typically, you know, you're going to have your chlorhexidine prep pad or prep sponge, and you're going to clean all the way around. And again, we don't want this movement. We just want a lift, and then you can clean 360 degrees around. It's very hard to do that when you have an adhesive securement device. It's very hard to do that if you have sutures holding your lines in. But with this anchor, with the SecurAcath anchor, you absolutely can clean like all the way around, right? The other thing is you can not only clean, but you can let it dry. So the beauty of it is you can get full skin contact, right, with your friction, back and forth, hashtag, whatever your policy dictates. But we also know that if chlorhexidine doesn't dry completely on the skin, you will you will see an increased risk of a topical reaction or a rashy area underneath a adhesive dressing. So we also teach to just hold it in place for the 2 minutes that it has to dry. Because often what happens is if you don't let it dry, it can get wet, you know, right in here, and you're not able to let it dry completely in the full area. But again, with the SecurAcath, you are able to do that. So there is a sweet spot, because like I said, you don't want to be doing this. You should be able to lift straight up and down the SecurAcath, well, you know, your line in the SecurAcath without any discomfort. If there's discomfort, you're moving it against the grain, I like to say. Just find the sweet spot and you're going to move it up and down.
So I always say, don't treat it like a corkscrew. The only wine you're going to get is one that you can't have for a drink.
Yes, I mean, you just don't want to be doing that, and
you don't want to twist it. You want to lift it.
Patients will feel pain, and I do get called once in a while, people saying, "Oh, you know, the patient is really complaining of the SecurAcath. They want it out. You know, they're crying. They're very upset." And of course, we have to address that. You can't just ignore the reports and complaints. But I would say 9 times out of 10, I will come and all I will do is remove the dressing, and I'll just let the area kind of breathe and sit, you know, depending on where it is. And the patient will say, oh, okay, good, thanks, you've removed it. And I'll say, no, actually, I didn't. What I've done is I've removed the sticky dressing, and I'm just, you know, kind of found the sweet spot and let it sit properly. It's really important that the anchors sit, you know, not twisted or corkscrewed, like Laura's saying, that they're completely flat within the subcutaneous tissue.
We have another question from the audience. The question is, can you use SecurAcath post over wire exchange or only on a new insertion? So I guess the question or variation of that question would be, can you put it in an existing insertion site after it's been in a while?
Yes, you can. So I do that. Our team does do that, especially for PICCs and tunneled lines. The tunneled lines, the ones in the chest that have a cuff, again, I spoke to that where sometimes the patient doesn't adhere to the cuff well enough. So I do get called a lot to put in a SecurAcath after the fact or after the fact in a PICC. So it can be done. What is required is a bit of local freezing. So typically lidocaine. You can use a topical agent also. You do need to be able to, and what I use is I think I have one right here. The
tissue
introducer, the introducer dilator in your peel away, we have those as single use items, and you will have to widen the track that is under the catheter itself. So obviously with some topical or intradermal freezing, the patient will feel minimal discomfort. And what you want to do is go into the track of the catheter. The one thing that people get wrong when they're trying to do that is they think, oh, I'm just going to get a scalpel and do a dermatotomy and make the incision wider. That does not help the anchor get into the subcutaneous space. You actually need, you know, a reverse tunneler, I say, happening right under the catheter. So you can put it in place properly once you get a good track under the catheter. For those of you that don't know and that are not inserting, the SecurAcath is actually folded in half and the anchor becomes one single piece, and then it's inserted into the tunnel. So again, the reverse tunnel, I call it. So again, having an incision with a dermatotomy with a scalpel is not going to help. It's actually going to make it worse, because then the anchor can, you know, move if the incision is too wide, if you've done a dermatotomy. So again, it can be done. It can be done once a catheter is in place. You will need local freezing, and you may need to just ensure that you have a deep enough tunnel to get that in. So depending on how long the line's been in, you know, you might have to massage and kind of work at it with your local freezing and your tissue your dilator that's in your peel away sheath.
I took the question to wonder if you could just exchange the catheter and leave this base of the SecurAcath. So pop SecurAcath lid off, wire, pull the catheter out, put the new catheter, and while the base of the SecurAcath stays in place, and then get your new catheter in place, and then just snap the, you know, so not replacing the SecurAcath. I've not heard that being done though, but I assume you could.
No, I mean, I would recommend new catheter, new SecurAcath, but you can use the same track. So if the existing track is there, you know, again, when we've done this in drainage catheters, nephrostomies specifically, when they replace the nephrostomy tube at 90 days, the recommendation would be to replace the catheter. So once the guide wire's in, remove the base, put the base in, and then actually thread the catheter over the base.
Yeah, but you know, I mean, I guess technically, Jeff, if that was a question.
Yeah, say you don't want to replace the SecurAcath, you don't want to get a new one, you don't want to pay for a new one or whatever. Theoretically, you could leave it.
I guess you could. You'd have to ensure that you know, it was cleaned very well. Yeah. But I think that it should be, the policy should dictate that new catheter, new SecurAcath. But yes, you know, as we know, as clinicians, sometimes the situation lends itself that you don't, like you just said, you can't get another SecurAcath. You're in a rural setting, you know, you're in a community or a hospital that doesn't have a new SecurAcath, whatever the situation is. You know, I think as long as you're using some critical thinking and you're trying to clean it as well as possible, I guess it could be done, but not saying that it should be done.
Yeah, and then Nadine has made a comment that, you know, if it's going through a sheath introducer, that might make it difficult to keep the same SecurAcath also. So I could see that point.
Hi, Nadine.
Somebody also asked about translations. So we might have joined a little late. If you're looking for translations, there's a closed captioning function on the bottom of your Zoom window. It's going to have closed captioning, and you can select the language and it should translate for you as we're talking. So please click on interpretation or closed captioning and then select your language translation. Obviously, we're delivering this presentation in English, and the translations are computer generated. So let's hope that they understand some of our terminology. But thanks for your patience, and we're very excited and look forward to hearing your questions. And I see one from Fernanda. She's from Brazil and heard that they just got authorization to use it in Brazil. And that's true. Yes, Anvisa's approved it in Brazil. The question is, what type of pain do patients complain of? And if that happens, how do you treat that?
Hi, Fernanda. So is she going to hear my translation or are you okay with
I
English?
hope so.
Okay.
Let's go for it.
Okay. So Fernanda, the pain on insertion is prevented with lidocaine. So we use lidocaine for our insertions for the line. So that would cover the anchor insertion. During dwell, so, you know, for dressing change or, you know, care and maintenance, there should be no pain. There will only be pain, again, if the anchor is twisted or too tight in a position that is not allowing the anchor to sit flat in the tissue. So the way to prevent it during the dwell of the catheter, so during therapy, is to ensure that it's completely flat and deep enough in the skin. The only way to fix that is to change the dressing and make sure it's in a good position. On removal, the pain is decreased and eliminated by doing the removal quickly and properly. So
Why don't you show that, Jocelyn?
So we do a lot of removals because we put in a lot of lines with the SecurAcath. And the one thing I've learned over the years is the quicker technique that you use, the faster you do it, the easier it is. So when people are learning how to remove these SecurAcaths, the biggest problem is they take too much time and they're too gentle. And we have to really equate it to other things that we administer or that we remove. Like when we, you know, give a needle, when we give an injection, when we remove staples, we don't do those procedures gently or soft, you know, we do them quite quickly with intent. So on removal, if you can see this, you know, you have to fold it in half. Jeff and Laura will hate me, but I don't recommend cutting. I recommend you can cut the device in half.
I love that. I'm a folder. I tell everybody
you should be as efficient and as quick as possible and fold it in half and get in a position where you can just easily take it out swiftly with intent, not gentle, not softly. Don't take your time. You know, you just want to, you know, you think about the other types of procedures we do for patients. Again, like giving an IM injection or, you know, removing staples. Those are two common procedures that we see in the hospital. And we don't do those kind of gingerly or gently. We do them with intent, and there's less pain when we do these procedures properly. So again, it's folding it in half. There is an option to cut it, but I will caution you that it takes a lot of force to cut it. It takes a lot of time. You know, we're folding it in half and just getting your fingers right in there and ripping it out. Bad terminology, but just with intent and pulling straight up is the best way to do this.
I agree. And Jocelyn, one of the things I like to highlight, I know I'm probably smaller on the screen, but if you can put your finger behind the feet and push that up to your camera so they can see the fact that they're not sharp. I think everybody sees the metal and assumes that the metal is sharp or can cut or harm. And I think the important thing to remember is that they're laser cut and polished and gentle. So there's no ability for it to cut or tear. And so the appropriate technique, as Jocelyn showed, is a 3-finger hold, a 3-finger grip on the device with your pointer finger on the blue, as close up to the legs as possible, and then counter traction over the insertion site. If you hold that skin taut, and I videotaped her doing it numerous times, her technique is excellent because she always has almost like she's peeling back the skin from the insertion site and pulling it up at the same time. And that's really, really important, is that counter traction.
Yeah. I wanted to make sure that was mentioned. The counter traction, holding your other hand, keep that tissue still. And I think the other thing that I see commonly is people tip the device upward and they don't have a good understanding of the shape and size of the legs and the feet. The more you can have this shape and size of those legs and feet and kind of in your head as you're trying to do this, you'll understand that you can't tip it up. You want to keep it level, and then she's tipping it up to lift the feet out. But so that's the movement you want to have, not the movement where you're kind of lifting the device up and trying to pull it out. It will hook and will not come out. So that's another thing that is a common sort of removal training.
And we're talking about the ideal and the proper way to do it, but I will say we do have a patient population here in Vancouver, downtown Vancouver, that can be very challenging and unpredictable with their behavior. And, they just want to get out of here. They're very impatient. And this anchor can come out. And because it is, I don't know if you can see, am I showing it, Laura? Like they're collapsible, I want to say. Like they fold over on itself. It's not like a staple that is completely stiff and very difficult to bend or fold in any way. It actually will fold over itself and pull out of the site. So I have had patients that have just, are pissed off and they're annoyed and they just say, I'm out of here. And they just yank the thing out. But the important thing to note is that there is not a 1 centimeter or 1.5 centimeter gash in their skin. All that's come out is it's come out through the site and it's just folded over itself and pulled out. So even if it accidentally got pulled on the door or the pump or the rail or the pole or whatever, there will not be a big gash. So I see that there was a question about.
Well, let me get one point. Susan made the point of that she had a patient that she said she needed to cut it because it wouldn't come out using the fold method. The patient said the pain was really bothering them when she was trying to do fold, so she cut it and then it came out much easier. So that's why we do train both, because it's good to have both, in your head. So when you try one and it's not going great, you have the other one as a backup.
Right. It's also really important to make sure the catheter is not in your way when you're trying to remove it.
Yes.
So removing the catheter first. If you're going to end up needing to cut it, the catheter has to be removed anyway at that point. You don't want scissors near the catheter. So I always recommend removing it. It's not wrong to leave the catheter in place, but I find the catheter can be an obstruction when you're trying to pull the feet out, especially as you're learning.
So that's interesting. So our policy in Vancouver is to keep the catheter in until we remove it. So,
but your team pulls the catheter and almost stretches the insertion.
Yeah. So what we do is we use the catheter up against with the tension to kind of open the hole up of the insertion site. We kind of use that piece. So this comes out and then the catheter comes out. And that's really important for the IJs, because I really, when we started looking at the IJs, I don't want to remove the catheter first because there's that risk of air embolism and issues. We want to remove the securement device first and then deal with positioning, having your petroleum dressing ready, etc., and to remove the catheter properly. So that's our policy in Vancouver. And again, that's just because we've been doing this for a while. And I've been able to see the evolution of what works best at the bedside for our staff. So there may be other ways that your policy dictates, but again, you just have to think back to the basics of, the particular patient population, where they are, whether it's an IJ or a PIC. I mean, there's very different clinical situations, whether or they're in the home for community. So
we have a question from we have a question from Kirsten. Oh, but there's one you skipped. I want to cover that.
I know. I was going to get back to that when we get to placement.
Okay.
Just because I figure we're on a roll with removal here, this one fit right in with there as for Jocelyn. Do the nurses on the floors remove these? We have issues with having staff do enough removals to remain competent, but it's sometimes hard for us to be able to get away and remove them all in order for patients to be discharged.
So I'm very fortunate. I have a specialized vascular access team. So they do the majority of the removals, but there are certain areas like in critical care and cardiac units and general surgery. So I have like 3 other inpatient units that will have nurses that do it. But in general, it is my vascular access team that do them. In the community, it would be community nurses that do it. So when there's a transition of care into home infusion programs, they would do it.
And Jocelyn, on that point, what resources are available to someone who doesn't know what SecurAcath is in the community, or maybe at another facility if a patient transferred from one hospital to another?
Yeah, so I mean, technology wise, there's apps, the SecurAcath.com has a great app. And that's been very helpful, especially in the community, because they, they don't necessarily have their laptops or their computers with them. And so that has been very helpful. They have a lot of good quick tip sheets. We've laminated those things that Jeff's showing there. We hand them out, we put them on our WOWs, which is our workstations. And we have it in our policy that is also available on our computer. Call it the Connect, where they can easily download a quick tip sheet. So SecurAcath.com though has the best visuals in terms of simplistic pictures of what to do, and as well as video, some short video clips on what to do for any type of issue that you'll have with the SecurAcath.
And for those in North America, the app has a built-in phone icon that takes you right to our 24/7 hotline. And I love that feature. For those that are new to the device, we have a fantastic team supporting that hotline. One of those team members is on this call, and shout out to Steve Wilson. Woo-woo. And we really appreciate the support. And if you call ahead of time, Steve can even do a quick in-service, some educational support with you ahead of time with your dressing change, with your issue, or with your removal. So I wanted to make mention of that. And is it okay, Jeff, if I bounce back to Kirsten's question?
Yeah, I just want to make Susan did say that she had a nurse that removed the catheter but didn't know how to remove SecurAcath. So she went and watched YouTube videos and figured out how to remove it. So the videos themselves can be very helpful, especially when you're new to the device. They can have you, it's really not that difficult advice, but yes, you do want to be able to see it before you go and try to remove it on a patient. So that's exactly why we have those out there, is for those situations. And now the one that you want to go back to is jumping back to a placement type question. What happens if post-insertion the patient is quite oozy or bleeding heavily? There are a lot of little ridges on SecurAcath that I'm afraid will get coated in blood, therefore difficult to clean and potentially an infection risk.
So, I mean, there are other products that are compatible with this device that you can use to help bleeding. So for a predictable situation that we will use a hemostatic agent, such as, I'm going to say other brand names here, such as Stat Seal or tissue adhesive like Secure Port IV. But in general, if it is unpredictable situation and you think you've had the bleeding under control, and the next day that it's not under control and you have not used an agent to help with that, the dressing, obviously you would do a dressing change, but it actually is extremely easy to clean, with your your sponge applicator with chlorhexidine. You can also, if you're using the patch that Laura's showing there, that'll absorb some of the
I wanted to show
you're showing. But yeah, so when you lift it up like
cinching,
that,
you get the hemostasis below the feet. So sometimes what happens is when it's placed, there's a gap. Can you see me?
Yeah, we can see
if I'm
it.
showing that. Yeah, so there's a gap between the two, and what we want to do is initially at insertion is pull the two together and hold for hemostasis at that gap. That way the initial clot is formed below the feet and doesn't allow for that blood to find its path between the two. And that then, as Jocelyn indicated, if you use a glue or a hemostatic, you can apply that. Or if you just simply use a sponge dressing or another type of dressing, that works as well. So again, in a predictable setting, You might want to be more proactive and utilize something like a liver patient, a patient with low platelets or bad INR. So you want to always, regardless, cinch it so that way that hemostasis is formed below the feet and at that insertion site. That cinching technique really mitigates most of the bleeding that we see.
So someone's asking to show how it's inserted.
Yeah.
So I'm going to launch into
Go ahead.
that. So once you have your catheter in place, so remembering that when we insert, and I'm showing a pic here, so this is applicable to any type of line. When we're doing a line insertion, you have already used some type of local anesthetic. So I get this question a lot about the pain of inserting the SecurAcath, but really on any line insertion, you're going to have local anesthetic on board already. So the area will be well frozen, or should be well frozen. The way that we do it for our PICCs in our upper arms is that once we have it in, so now depending on the type of catheter you're using, you know, you're going to have to do your measurement and your technology, your ECG technology. We typically need, for PICCs, we need 3 centimeters in order to accommodate the SecurAcath. All right, so and that is the same for your IJs. So in saying for the IJs, for someone's question, is we did have to go to the 20 centimeter long percutaneous non-tunneled lines. Obviously with PICCs, they're typically trimmable, so you're going to have to ensure that your measurements include +3, as always say, right? You need that in order to be able to fit the platform properly and the anchor within the skin. So once you've reached your cavo-atrial junction, your max P wave, everything is good, you are then going to, and again, I like to use the catheter itself to kind of increase the tension and the torque to get the site open. And what you're going to do is you're going to fold this in half, and obviously I don't have gloves on, but with the gloves you will have a bit more grip on this device, and you're going to hold it, and this is what I teach, is thumb and middle finger and your forefinger on the blue part, and as you insert, you're kind of going to go in sideways here. Hopefully you can see, and you're going to get into the hole, right? You're going to get the feet into the hole, and this is my technique. I then turn counterclockwise, and then I hub it. I say hub it. I push the anchor all the way to the orange, right? I've hubbed it, and then I release it. If the wings do not open and release easily, the anchor inside has not engaged properly. That just means that you're not deep enough, and it's getting caught in the top layers of the subcutaneous tissue, which is not ideal, and it will cause pain. So in that case, I would then fold again. And again, remembering that they have some lidocaine on board typically, or whatever type of anesthetic you're using, local anesthetic you're using, I'm going to try to get it so that I can easily push in and out and hub it, open it. And again, this should be easy. It should not, you should not feel any tension or grittiness, I like to say, within the skin of opening that. And then at that time, you're going to put your catheter within the blue track. And it's important to make sure it's within the blue track. All right, it's a little track that holds the catheter in place. Here's the larger one here. And then once that's done, it's nicely in place, then you're going to snap, and I say that it requires 3 clicks to properly secure the lid on. So the very first, and this is my teaching, I don't know what SecurAcath teaches, but I teach to snap in the middle and then 1 on each side. So if you get a good, secure fit right away, that middle click is usually all you need, but just for good measure and just to be safe, we do 1 on each side, click, click. We then do a look to make sure that the catheter is within the trap, right? And then our final check is to make sure that the anchor is completely flat on the back. And typically it's just by feel. right? And then once that's done, and again, note I'm not doing this or twisting, I'm just doing this. I then place it on the patient's skin. You're going to do your clean again and make sure there's no debris, you know, ultrasound gel, whatever, any other stuff that's accumulated there, blood. If you're using tinted skin antiseptic, you know, make sure that's all gone. And then we're going to put a Tegaderm dressing on top. Jack has a, hey, Jack has a video.
There's a, before Jack's video, Jack, if you'd like to show your video, I'd be happy to let you show that. There's two more questions I'd like to jump in with. One is that there's some Brazilian doubts that there's a complication rate compared to stat lock. Can we talk about the literature and the evidence related for our stat lock compared to SecurAcath?
Sure. So complications meaning?
What can go wrong with a stat lock versus what can go wrong with a SecurAcath?
Well, so we used stat lock for a long time, many, many years before we took on this subcutaneous anchor. And I will say that complications that we saw with stat lock were the two main ones were skin issues underneath the adhesive pad of the stat lock, because our picks are lasting not just 1 week. They're typically more than 1 week. You have to do that dressing change every week. We were seeing skin breakdown, and you know that, of course, that's a teachable moment. It's about the chlorhexidine not drying. I mean, there's many things happening there, but again, we're seeing an increase in skin irritation because of the adhesive. The second thing is malposition. So malposition was a big problem for us, because when you deal with the stat lock and you have to change the dressing and remove it, and I don't have a platform with it, there is risk for micro movements of that catheter.
I can show that video.
So once you change it and there's nothing holding it in place, so once you've remove the catheter from the stat lock, and then you have to remove the stat lock, and, you know, clean and do everything, there is a high risk of malposition if you are not, you know, pristine in your practice. And I will say, you know, I have to deal with 2,000 nurses. They're not pristine in their practice. So we were seeing micro movements, and it could be 1 centimeter today that Jocelyn moved. It could be another centimeter that Laura moved, and Jeff moved 2 centimeters. So suddenly we have malpositioned this catheter 5 centimeters, and that's over 3 weeks. You know, that's a big problem. So what I wanted to track back then 12 years ago was, how can I eliminate this risk? How can I decrease the risk of malposition? Because as we know, with malposition comes delay in therapy, possible replacement, most likely replacement of the line, you know, undue inconvenience for the patient. So those type of soft costs, I would say, the soft complication impact was very big for the patients. So a lot of the validation for me bringing it in had to do with the cost of, you know, a stat lock being changed every week to this one-time cost, but also the complication of malposition and skin irritation. We had to do a lot of troubleshooting for that.
And Jocelyn, Jeff's going to bring up a pistoning video that emphasizes the point that you were just describing. And then Jack, you're up with your video on insertion. So this is during a dressing change.
So if you are looking at that non-SecurAcath catheter closely, you can see that as soon as you release the catheter, it starts moving, because obviously there's nothing holding it anymore. And then you're trying to clean and keep it still, but it does move. There's just no way to prevent it from moving. And so that movement, pistoning, migration is obviously very common when you are not using SecurAcath. All right.
Jack.
No, I got it.
Welcome to
Is
the
he
party,
able to
Jack.
share?
I just gave him permission.
Oh, okay, gotcha. So I have to stop sharing?
Yes, you do.
Go, Jack.
Okay, hold on there. I had to stop.
I'm trying. Hold
I love that you're crashing the party, Jack.
on.
I'm sure there'll be an extra round of applause.
So this is just an insertion in a live patient.
You have to share your screen.
All right, I get it. Hold on.
Okay.
I'm gonna unpin you, Jocelyn, so his screen will share. There it goes.
So this is in, let's see, is that my screen?
Yep.
Yeah.
Should be.
All right, so this is a live insertion. Nothing's playing, huh?
Not yet.
It's like when
There it
you,
goes.
There we go.
okay, yeah. So that's how we're going to put it in, and then we're going to release it into. Good, at an angle with the feet,
So note that he's using the
Sink it
catheter to
down.
kind of open the insertion site.
going deep.
That's exactly what,
Nice,
yeah.
nice.
And open the,
Testing
yeah.
it. Good. Nice.
And those
Put the
dots
cover
have to be
on.
aligned in that channel. And
You're
those
gonna press
wings
it down in
should
the
be
middle,
parallel,
right?
the
And then
catheter and the
side.
SecurAcath wings.
Now you're going to.
Beautiful.
Very
So, yeah,
nice.
and you'll note that there, you require about 3 centimeters external. So you have to be very careful with your measuring, especially those of us that are doing picks at the bedside. And when you're educating for the IJs, that they do need that extra length, because if people are used to going closer to the hub, to that integrated wing, it's a problem. You won't be able to get this platform in there.
And there was
It
a
wasn't-
question about damaging the catheter. And
Yep,
you
go ahead.
won't damage the catheter.
No, you will not. Because of the way the anchor feet are, it's not sharp enough. It's never at an angle, but it's definitely not sharp enough to slice a catheter of any material. And we do insert silicone catheters also, and it has never done any damage to a polyurethane or silicone catheter.
Yeah, and we had to test and approve that before we could ever get the device approved too. So it is a blunt, non-sharp, and yeah, they do not cause any sort of damage to the catheter or really any of the tissue in the sub-Q. It's a blunt dissector, so it's just going to push things out of the way. It's not going to cut through anything.
So I see, Laura and Jeff, that someone's asked about glue at the incision. And we do put tissue adhesive. Our brand is called SecurPort IV. We do put tissue adhesive on top of so we would put it right here after insertion. So you have to achieve hemostasis first. So our policy is to hold pressure until you've achieved hemostasis, and then we will put a couple of drops of glue. So it is completely compatible, and the SecurAcath, works fine with it, and the tissue adhesive there's no interaction with it. It works fine to seal that site. So yes, we do that.
So I wanted to just show the device in a magnification. So this is above it, a nitinol guide wire out of a standard pick tray, most common brand that was available. You can see these edges of that nitinol wire compared to the edges of the SecurAcath feet. From the ball to the ball on either side of the feet is 1 centimeter, and the thickness is 1 millimeter, and they're 1 centimeter long. And you can see this curvature is designed with perfect intent to be able to reside under the subcutaneous tissue without a lot of friction and without a lot of concern for damage to the catheter. And I know somebody said they saw a catheter break right at the edge of a SecurAcath, and that is not impossible if the catheter was pressed or kinked. So we don't, the force there would have probably been more because of a kinking action, or the catheter might have been too tight under the dressing or turned at an angle. If that has happened recently and you have the device and the catheter, we would be welcoming it to be returned and do a full investigation and assess that for you. But again, we have not had any proof or evidence that the device causes it, and we've tested it thoroughly with several brands of catheters to prove that it will not damage the catheter.
You definitely want to make sure you keep the suture wings under the dressing. You don't have any undue stress or force on the catheter outside of the SecurAcath, because obviously the catheters, they're not perfect, and some are less perfect than others. And so any sort of stress you put on those catheters, it is obviously possible. You know, catheter leaks happen with or without SecurAcath. We've seen that for years now. And so the SecurAcath actually creating damage or leaks in catheters is it would be quite difficult. But if that catheter already has some sort of weakness or something in the structure of the catheter itself, obviously it can be brought out by any sort of stress being put on that catheter. So that's what we've seen.
So yeah, when Jeff's talking about the wing, this is like, so for my pick, this is the wing that needs to be under the dressing with the device. So it's very important, because if this is outside of the dressing, it will contribute to pull force. And again, it will contribute to pain. So, and discomfort for the patient. So it really needs to be within, you know, in a very slight curve. So it's not kinking the lumen, but it has to be within the dressing.
And leave yourself a little extra catheter length if you know you're going to want to turn the catheter in a different direction. The more you leave, the better, because if you have the suture wings of the catheter butted right up against the SecurAcath, you're going to be absolutely creating some stress on that catheter every time the catheter is moved. But if you give yourself a little wiggle room, a couple of centimeters, it would be great. If you're going to bend the catheter, it prevents kinking, it prevents stress. It allows you to put the catheter in the orientation that you want, and just make sure that suture wings and SecurAcath are all underneath the same dressing.
So again, it's the integrated wing that he's talking about. So on this, or there's an integrated wing on every catheter that we see.
So we have, I don't see any additional questions. Jeff, did we miss anything? Oh, what should I do if the legs are crossed over each other when it was placed?
Mm-hmm.
Yeah, so that's a great question. So what we would do, and that's why we do that triple check, is I would remove it and place it back in. So if I was unable to open it easily, meaning it's flat, and I would see that it's crossed here, I would just fold it again, and try to get it deep enough into the tissue and hub it, and try to get it so that it opens easily, and to make sure that it's not crossed.
And I'm going to add to what Jocelyn's saying. So she's holding the box, but what you should be doing is the opposite hand should have traction on the skin, really stretching extremely tight on the skin at the insertion site as you're making that advancement. Sometimes what happens when those legs cross is that you're in the dermis, and the dermal tissue is denser, so the feet will spring on it and cross over. So what you want to do is just fold them and advance it forward, but the counter traction on the skin holds the skin taut as you try to advance past the dermal tissue. You can also use your ultrasound. This is something that our pediatric focus group taught us in recent months, and we're starting to apply it. But if you're not sure, you can actually take your ultrasound probe and put it at an angle. It's a steep angle, almost opposite of what you do to track your needle, and look at the feet to make sure that they're visual underneath the dermis. And you can tell the difference in the density of the tissue. You can see the dermal tissue, and then you can see that subcutaneous space. If you watch your lidocaine bleb, you can see that space expand when the lidocaine is in it, and the feet should be right in that same space where your lidocaine rests. So when you put your feet in, that's the area where you want to do it. The ultrasound trick is pretty cool. I just started using it. I just started using it with training, and I need training videos, Dennis. But I think that trick is going to help people know that they're in the right place. Not as a standard, not as a requirement, but it's a great way to learn that you know what it feels like when you're in the right position.
So I see a question here about can you pull, what happens if you need to reposition the pick So it's very easy. All you have to do is remove the lid, remove the cover of the SecurAcath. Sorry, if we could see this. It's like a Tupperware lid, I like to say. And then you are going to, once you open the lid, you've got it, you obviously will have your dressing tray or some sort of sterile field. Make sure that this does not get lost, you know, and
You need that.
because then you'll need a brand new SecurAcath. And then you're going to, you know, pull back, you know, 1 to 2 centimeters or whatever is required. And then you're going to place this back on. Very, very, very simple to do. But you cannot do it with the lid on. You have to remove the lid. Very easy to do.
Yep. Very easy to do, and it's great for especially your acute central lines. You know, often sometimes we put those in and then the x-ray is achieved and we realize we need to pull that back. So you pop your lid in your sterile dressing change, pull back 1 centimeter, 2 centimeters to you're in the appropriate position, and then close your lid back on. Another thing I've noticed with acute IJs is our anesthesiologists love them going up the neck, and our bedside nurses need them down off the shoulder. And so with SecurAcath, what is a beautiful thing is we can train our anesthesiologists to do what they want to do, but before they send the patient to PACU, they can fold and redirect it so that the line is coming off the shoulder. And that way Jack will be happy when he sees it in the ICU to take care of those patients, and he knows his nurses can manage that dressing more effectively.
All right, I gotta say this crowd's got some great questions. I mean, this is the best audience question that we've had. So thank you very much. But the one that came in the first there was, what if what do you do if a patient continues to complain about pain when SecurAcath is in?
So I still do get that once in a while, especially we had it a lot, especially in the learning curve when we first started using it. But it really, honestly, 9.5 times out of 10, it's because the dressing is on and the SecurAcath is kinked or twisted or turned over so that the anchor is in an incorrect position, causing pain. That is, you know, 90% of the time that is the issue. So what we do is we remove the dressing, let it breathe a little, let the patient, you know, kind of be assured and not feel that pain. Because what I've heard is it feels like a pinching, stabbing pain right in the top layers of skin, which can be very painful, especially in the upper arm or the neck. So what we do again is remove the dressing, let it breathe, get your supplies ready, do a brand new dressing change, and ensure, so it's all about positioning. Ensure you find that sweet spot on the skin so that it's not twisted or kinked or corked over in any way. Place it down nicely. If you have a lot of external measurement, make sure that this is just a little L or, you know, J loop, just a very gentle curve. Put that dressing on and make sure that this is not twisted or kinked in any way. So it is very rare that I get called for a patient that's having pain that I remove this. It's very, very rare. I will do everything else to try to make sure it's in the correct position first. And most times that is what resolves the issue, the pain issue.
You see, this next one's kind of in line with that. It says, can you coil the pick under the dressing if there's too much catheter out, or does that cause pain and discomfort under with the device?
So it will if you do this.
Yeah.
It won't if I get a lot of external measurement here, I'll just show you. So here's a lot of external measurement, right? So if I do this and put the dressing on, yes, that's going to cause pain, 100%. But if you ensure that the sweet spot's found and you're going to do this, right? You want to make sure that it's not kinked so that the lumen doesn't kink over. I don't have enough pad here to show you, but even like this, you know, and we have a very large adhesive dressing that would accommodate this. So it also depends on the type of dressing you're using to make sure that this, you want to still be able to see the insertion site, but you need to have this wing within a stable adhesive dressing, or else it'll cause tension and pull force on the catheter.
Mm-hmm.
And then I mentioned to the person who asked that question, but this goes for anybody. If you have specific nuances in your patient population or your dressing combination, the materials you're using, on our website, you can create a booking. You can create an appointment with us, and we can take 15-20 minutes and go through your specific needs and do a demo pad with you, get some pictures so that you have best practices specific to the materials, the catheters, the dressings that you use at your facility. Or your local rep can do that with you as well. So if you're not sure who your local contact is, you can also message us. We'll be happy to connect you with the right person and make sure that that training and support is available to you so that you have the best connection with your product and SecurAcath.
So there's a question about repositioning after. So you can do that, but again, you absolutely can do that. They should depending on how long after insertion, the initial insertion, you may need local anesthetic, some sort of numbing. That I would recommend that, but it can be done, and you would just have to, remove the lid, remove the device, making sure that your catheter is still in place, and of course, if it's a PIC, you want to make sure that the external measurement hasn't changed too much, because you've used most likely ECG to get that tip location, and then absolutely you can replace it.
You can shift it, fold it, turn it the orientation you want, release it again, and then put the cover back on. I said this is a comment here, but it says I saw a PIC that got twisted quite badly outside the SecurAcath, so nurses have to be careful. So what that's saying is, when dressing changes are happening, if you got a lot of excess catheter, you can't have it be getting twisted, because that is going to obviously be stressful on the catheter, cause kinking, cause damage. So yes, you do want to make sure that that is not being twisted, because obviously the catheter is being held in place by the SecurAcath device itself. So any twisting beyond the SecurAcath is going to cause a lot of stress to that catheter. So yeah, that is something to be aware of, and to be part of training, and just make sure that you can obviously move it, and you have to lift it and stuff to do the cleaning, but you don't want to let it get twisted.
Yeah, it absolutely can happen if you have too much external. It's really important to know, if the dots are still visible on the catheter, to make sure they still are, and that they're not twisted or stretched in any way, as well as the labeling on the wing. That's another visual cue to make sure it's not twisted in any way.
There was a question about, what do you do if the legs look like they're crossed after you've placed it?
So if that's the case, again, you need to do your check to see. That's our final check when we insert them, but you would have to reposition it, and by saying that, it's folding and ensuring that you're deep enough into the dermis, and the platform should open very easily. There should be no resistance or no grit as you're opening it in the skin. You should be deep enough. If you're too superficial, there is a high likelihood of the crisscrossing of the anchor legs. So just folding again and making sure you're deep enough and hubbing right up to the platform, and then opening it up and then pulling back and checking.
We're going to squeeze in a couple other questions. The question was asked, could it be used on pediatrics? And Kathy, who has used it for a while, is on pediatrics, answered that already, saying yes, use it all the time. So we've had a lot of success with this device in the pediatric and even neonate populations. So yeah, the answer to that is absolutely yes. And then the other one is, what is it made of? And any allergies need to be aware of prior to using.
So I can handle that one. So the feet and the anchors are made out of a nitinol, which is a nickel titanium alloy. And yes, there is a warning in our IFU regarding the nickel, but it is a discretionary caution here. There are many examples where it was used, and we don't have any information that shows an anaphylactic level reaction to SecurAcath. You have to weigh the risks benefits of a dermatological reaction versus a dislodgement or replacement of your catheter, vein preservation for your patient. So I would say that If you were to find a problematic reaction, you can remove the device in the presence of that, but it isn't something that we've seen prevalence of, and we don't necessarily caution for. I have other information in writing if anybody needs that to consider, but you can also find in all of our published literature, we have over 25 peer-reviewed studies and tens of thousands of patients. Most recent one was over 10,000 patients and 1 million catheter days and 0 report of incidents of allergies in that patient population. The plastics are biocompatible plastics. There's an elastomer, which is the blue portion, and then the polymer. It's just a standard medical grade polymer on the orange portion.
Yeah. The other, did you make the point of if anyone ever did have some kind of serious reaction?
Yes, you can remove in the presence of a concern or a reaction. So if you choose to use the device, or maybe that allergy wasn't disclosed and you find a concern, the device is easily removed while retaining the catheter in place. You just have to put an alternative.
Laura said, I don't believe we've ever really had a confirmed reaction to the nitinol material that was severe enough to warrant any sort of issue with an allergy removal. But we have seen skin reactions due to not allowing the chlorhexidine to dry completely before slapping a dressing on there. So that is, sometimes people think there might be something going on with SecurAcath, but it's really just the fact that they they applied the dressing and the CHG and alcohol irritated the skin. And then I brought up the neonates, so somebody said, neonates, what size catheter? So what's the answer to that?
So the smallest catheter is a 2.6 French. There's a great textbook online, and some of the neonatal pictures that you'll find in this textbook are on chest lines, so not just PICC lines in the arms and legs, but in other lines. So it's also been used on drains. There's several studies on our website that include pediatrics and neonates. I believe the smallest neonate in our published literature is like 22 weeks gestational age. It might be 25 weeks, something in that range. But you can definitely find more information about that on our website. I know we're kind of running over. Thank you guys for your time. How do you place the bio patch? I'll answer that question as we wrap up, but basically you lift the device up, slide the disc around so that the disc is completely around the insertion site and the SecurAcath, and then you lay the SecurAcath down on top. You can see here the bio patch is on this one right here, and it's completely around it. Any disc product, any other agents that we might use if you have a patient with questionable skin integrity. Somebody earlier mentioned they use it with their EB patients, their epidermis bullosa. You can definitely incorporate other types of wound dressings as an adjunct to the SecurAcath if necessary. If you have questions that didn't get answered, your passion and commitment to being on this call was really exciting for us, and we're thrilled. We will have another call with a different speaker in February. Follow us on Facebook, Twitter, LinkedIn, and you'll see those dates. We'll be posting the next meeting with our future guest, Matt Sinner. Thank you, Matt, for agreeing to host our February meeting, and we look forward to having some of you join us then, or tell your friends that you enjoyed this call and you got your questions answered so they can join the next call. We really do appreciate you. We appreciate you, Jocelyn, and Jack. Thanks for chiming in and sharing your experience.
I put my email in the chat if anybody wants to email me directly. Thanks, everyone.
Really appreciate everybody's participation. Thank you so much for joining us today.
That was excellent.
Thanks, everyone.